today's episode of Myeloma Crowd Radio, a show that connects patients with myeloma researchers. I'm your host, Jenny Ahlstrom. I'd like to thank our episode sponsor, Takeda Oncology, for their support of the Myeloma Crowd Radio program. Today is the end of Myeloma Awareness Month, so I hope you've had a chance to share myeloma facts with your friends, family, and online community, and to join our efforts to spread myeloma awareness while helping you get fit through our Muscles for Myeloma campaign. The Myeloma Crowd will continue Muscles for Myeloma through April. So if you haven't joined yet, Muscles for Myeloma is a fitness campaign you can join to set and achieve fitness goals, because fitness is critical for myeloma patients in order for them to get the best responses and treatments possible. At the same time, this campaign helps support the research being done by your myeloma specialist, because we have teams for myeloma academic centers. So we encourage you to register, set a goal, a personal goal, share that goal with your family and friends, and invite them to donate to your page. Donations will go to myeloma research at the facility of the team that you join. And this is our effort to help national research and gives you a way to thank your myeloma team with something that's meaningful for them, research funding, to help them find a cure for you. It's also a great way to work on your beach body, and summer will be here before you know it. And we have great tools to help you track your fitness and your diet. Now, today's show is an exciting one about the use of intravenous vitamin C or ascorbic acid to kill myeloma cells. Dr. Guido Tricot and his counterparts at the University of Iowa have been testing this in myeloma, and we are anxious to hear more. So welcome, Dr. Tricot.
Thank you.
Let me give you a brief introduction. Dr. Guido Tricot is director of the adult, I can never say this word, hematopoietic stem cell transplant and multiple myeloma. You can say it for me.
It's good. It's good.
Multiple myeloma program.
Adult myeloma and stem cell transplantation program. Yeah.
Mm-hmm. He's a Gary D. Arthur Professor of the Adult Bone Marrow Transplantation. And professor of the Department of Internal Medicine at the University of Iowa Hospitals. He has practiced myeloma at top facilities, including Memorial Sloan Kettering, MD Anderson, UAMS, the Greenbaum Cancer Center, the University of Utah, and the University of Iowa. Dr. Tricot reviews publications, including the American Journal of Hematology, Blood, Bone Marrow Transplantation, the British Journal of Hematology, and the Journal of Clinical Oncology, to name a few. He's also on the editorial board of Bone Marrow Research and Leukemia, the Journal of Blood and Lymph, and the Journal of Cancer Therapy. Now, Dr. Tricot has announced that he'll be retiring in July. And I was hoping to get, to get through this without choking up, but I don't think it's going to be possible. Dr. Tricot is very special to me, not just as a renowned myeloma specialist and a member of our Myeloma Crowd Research Initiative Scientific Advisory Board, but he's also my doctor. He's one of the most caring doctors I've ever met, and he's helped me every step of the way in my myeloma journey and my efforts on the Myeloma Crowd to help my fellow patients. His core focus has always been his patients, and he has thousands that truly love him. His diligence in his work of more than 20-plus years has been to help patients obtain their best outcomes, even when the protocols needed to get the deepest and long-lasting responses with the drugs available at the time were not popular. And now that science has caught up with some of his earlier work, most patients also now receive induction therapy, stem cell transplant, consolidation, and maintenance treatment, which is a relatively new development, but one he's been doing for many years. Because of his care, I personally enjoyed 6 years of complete remission, which has allowed me, to host this show and the Myeloma Crowd program so I can help others. And I'm forever indebted to him. I know you'll be greatly missed by many patients, so my apologies for the emotion, but we are very grateful. So vitamin C is nothing to cry over, but maybe we should get started talking about that topic since that's what people are calling in to listen to. When I was reading your paper, Dr. Tricot, I saw 3 key issues that you kind of talked about with today's melphalan and myeloma treatment. Maybe you want to talk about just the rationales behind why you decided to investigate intravenous vitamin C.
Thank you very much for this extremely kind introduction. One of the goals has always been to try to get to treatments that are not so toxic and to treatments that are selective and kill the cancer cells while leaving the normal cells as much intact as possible. Unfortunately, most of our medications we have for myeloma, although they work well, they have considerable side effects, whether it's the high-dose melphalan, which can cause sores in the mouth and can cause diarrhea, and severe cytopenias, to the bortezomib, which can cause neuropathy, to the IMiDs, which can cause also neuropathy and also some degree of suppression of the bone marrow. There is never a free lunch with those drugs, and they have all their side effects. So we have been trying to find ways to use drugs that are less toxic. And vitamin C has been used as an anti-cancer drug since the 1970s by work of Cameron and Pauling, showing that it had anti-cancer effects. Unfortunately, in the 1990s, some of those experiments were repeated at the Mayo Clinic, but instead of by intravenous ascorbic acid or vitamin C, it was given by mouth. And when I say intravenous, I mean by vein.
Right.
And it's clear that there is a major difference between giving it through the vein and by mouth. The amount of vitamin C you can absorb by mouth is very limited, and you can never reach levels that are necessary to kill cancer cells. And there has been more and more recent evidence that if you give high doses of vitamin C, and we're not talking about 1 gram a day, but we're talking about doses of 75 to 90 grams, and you give it intravenously, that there is indeed potent anti-cancer effect. But
so when the tests were performed in the 1970s, how did they give it and at what dose?
It was given intravenously, and the doses were variable, but were lower than what we are using now, but higher than what could be reached by giving it by mouth, even at high doses.
Okay.
Yeah. But we now know that the doses that are necessary are in the 75 to 100 grams at one time. So the role has been studied in multiple academic centers, including the University of Iowa, in which it's one of the major players in the field of vitamin C. However, the cancers that have been studied have all been solid tumor cancers, such as brain tumors and pancreatic cancer, and ovarian cancer, and breast cancer, and prostate cancer. But it has not been studied in liquid tumors such as leukemia and myeloma. We also have started to understand better how vitamin C works, although there are still some parts that we still don't know well. And we know that in the presence of certain metals, such as iron, IRON, that high-dose vitamin C leads to the formation of what we call reactive oxygen species, or ROS, which basically cause oxidation and damage to the DNA and to the cells and make the cells die. Our studies have shown that when you look at myeloma cells and cells in smoldering myeloma, that the levels of iron in the cells is much higher than in normal cells. But in patients with MGUS, the monoclonal gammopathy of undetermined significance, the iron levels were not very high. And we have tried to find out why the iron levels are so much higher in cancer cells than in normal cells, and it's basically because of two mechanisms. You have to imagine a cancer cell, and on the left you have a pump that pumps iron in, and on the right you have a pump that pumps iron out. And the pump that pumps iron in is called transferrin, and the one that pumps iron out is ferroportin. And we know that in cancer cells, transferrin is much higher than in normal cells, so it pumps more iron in. And also at the same time, the ferroportin, which pumps iron out, is much lower in cancer cells. So you have more pumping in, less pumping out. You increase the concentration of iron in your cancer cells. In normal cells, there is an equilibrium where you have a certain amount that is pumped in and a certain amount that's pumped out, but you never get very high concentrations of iron. If you don't have high levels of iron in your cells, the vitamin C will not do any damage. So this is a way where we can now do something that's quite selective, where the more malignant the cells are, the more iron they have, and the more they are sensitive to vitamin C, and the lower the vitamin C levels are in the cells, the less sensitive they are. So the normal cells are almost not, you almost see any effect, while in the cancer cells, the more iron they have, the more they are going to be affected by vitamin C. And when you look at patients with myeloma in the beginning and at relapse, or patients with little disease and more aggressive disease, in relapse patients and more aggressive disease, those patients have myeloma cells with much more iron than the patients with more benign types of myeloma. So this is a type of treatment that will be especially effective in not necessarily up front, but certainly in relapsed patients. So we have done a series of studies in myeloma to evaluate the role of vitamin C. And these studies were basically done by Zhan, who is our major researcher, and his group, especially Ivana Fresh. And so, although I report those studies to you, the heavy lifting was done by other people, by our researchers here at the University of Iowa. So
yeah, they're a great team.
Yes. And the first set of studies was what we call in vitro studies, or tests studies in a test tube. And the first thing we did is we took myeloma bone marrow, patients with myeloma, we took their bone marrow, and we separated this in two fractions. Their myeloma cells and their non-myeloma cells, the normal bone marrow. And the myeloma cells died in the presence of the high-dose vitamin C, while the normal cells were totally not affected by it. And the same effect was seen in smoldering myeloma, but not in monoclonal gammopathy of undetermined significance, which we knew had lower concentrations of iron in the cells. So the next question we had is this indeed the killing? Is the killing due to oxidative damage, to the oxidation of the DNA? And to do that, we incubated myeloma cells with agents that protect against oxidative stress, such as N-acetyl NAC and such as catalase. And those prevent basically the reactive oxygen species to be formed and protect against the damage done. So what we saw is that when we incubated the cells with those agents that prevent oxidative stress, that we didn't see vitamin C killing myeloma cells. The second thing we wanted to see is iron indeed critical to kill those myeloma cells? And one of the ways we could do that is by incubating the myeloma cell with desferoxamine. And desferoxamine is an agent that chelates, that binds iron and makes it inactive. So if you do that, then you don't see any more killing of myeloma cells, which already gave us a good clue that iron was indeed critical. The other thing we did is we increased the gene for ferroportin. And you remember, ferroportin is the gene that is the protein that pumps out the iron. So if we increase the gene, then we will see much more protein ferroportin protein, and much more pumping out of iron. And again, when we did that, we saw much less killing of myeloma cells. However, if we increased iron in the medium where we incubated the cells with, then there was increased iron in the myeloma cells, and that increased iron resulted in increased killing of myeloma cells, making it very clear that iron was a critical player in the toxicity of vitamin C. And then a second set of experiments was done in mice, which we call in vivo experiments, to see whether not only this would work in a test tube, but also in vivo in myeloma, in mice that had active myeloma. And we used severe combined immunodeficiency mice, and we also made the myeloma cells visible by having the myeloma cells express luciferase, so that you can monitor the tumor progression by imaging. And we incubated the myeloma cells with carfilzomib, with melphalan, with Velcade, and with high-dose vitamin C. And the dose of vitamin C was 4 milligrams per kilogram, which was the dose that can be reached easily in patients when you give 75 to 90 grams of vitamin C. And when we did those studies, we saw that melphalan showed the best killing. As we all know, melphalan is still the best drug if it's given in high doses for myeloma. But we also saw that if you give vitamin C only, and you compare that to carfilzomib, that carfilzomib did not kill more cells than the vitamin C. Vitamin C was equally effective.
That is crazy.
And then we also tried Velcade, but it became very clear, and we also could confirm that vitamin C basically inactivates Velcade, and that you cannot combine those two together.
Yeah, let's talk about that for a minute, because, well, we'll come back to that. So keep going, because that's an important point I think patients need to understand.
Yeah. So most patients will already know that when you take Velcade, that you should not take vitamin C, and that you also should not take green tea at the same time. Then we went to combinations of treatment. We combined carfilzomib with high-dose vitamin C, and we combined melphalan with high-dose vitamin C. But the melphalan we did at the dose that we typically would give, 5 milligrams per kilogram, but also at 3 milligrams and 1 milligram per kilogram. And to our surprise, we saw that the effect that the mice survived equally well with the lowest dose of melphalan if it was combined with vitamin C than with the highest dose. So we were now able to reduce the dose of melphalan to 1/5, and even with 1/5 of the dose and adding vitamin C to it, we had the same killing as with melphalan given by itself at the highest dose. But whatever dose of melphalan we used and we added vitamin C, we always saw better effects when we added vitamin C. We saw the mice surviving much longer when you added vitamin C, whether it was at the lowest dose or the middle dose or the highest dose. But again, at the lowest dose with vitamin C, we saw the mice surviving equally well as with the high dose of melphalan alone.
And then when you combined it with carfilzomib and vitamin C, what did you find?
If we combined carfilzomib and vitamin C, we basically did not see any more effect than with carfilzomib alone or with vitamin C alone. So we did not see any additive effect or synergistic effect when we added those two together. So it worked clearly best with melphalan alone. And that made us think of, how should we go from here? And there are two things that, first of all, what we still need to do is to try to find out how the mice become resistant to the vitamin C, because ultimately all the mice relapse. They relapse later, but how do they become resistant to it? and how can we prevent the mice from becoming resistant to it? What do we need to add to it? But in terms of clinical studies, there are two ways we would like to go. And one way is to use it in patients who have smoldering myeloma and use it as a single agent to see whether we really see effect when we use it as single agent alone. And the other thing that we would like to do is patients who are not candidates for transplantation, who cannot tolerate the full dose of melphalan, to see whether we can give those patients a fourth or a fifth of the dose of melphalan, add high-dose vitamin C to it, and see whether they do equally well than patients who have melphalan alone at the full dose.
Right.
Okay? So this would make the melphalan available to many more patients than at this point in time, because as you can imagine, when you give the lower doses of melphalan, those mice have much less toxicity than the mice that got the full dose of melphalan, while it was equally effective. And that's what we also would expect in patients, that if we do this in patients, that they will have much less side effects and that they will be able to tolerate those relatively low doses of melphalan with vitamin C much better, while they could not tolerate the high-dose melphalan by itself.
So can I ask you a question about that? So sometimes I know melphalan can be given not in the transplant setting. So if you lower the dose of melphalan and you do the vitamin C with it, is that sufficient to do a full stem cell transplant? Like, does it kill enough for you to kind of reset the immune system like the stem cell transplant is supposed to do, or how does that work?
That's based on the mice data, that's what you would expect. But as you know, not everything that you see in mice translates directly into humans. And we need to do the clinical studies to show that you can indeed lower the dose of melphalan by 80%. And if you combine it with vitamin C, you're still going to see the same effect as if you would give full dose melphalan alone.
Yeah. Okay, interesting. And before, when I was, sorry I interrupted you before, but let's just go over that again, because you did explain how bortezomib is not to be used. But I just want to make sure, because when I posted this show, I saw a lot of people kind of say, well, my doctor told me not to take vitamin C, so why am I supposed, why is this going to kill myeloma cells? Or someone's posting about how lemons cure cancer and things like that. So I just want to be very clear about, if your doctor has told you not to take vitamin C, the reason would be?
The reason would be that the vitamin C is going to inactivate the Velcade and make it not work to some degree. It all depends upon the dose of vitamin C you give and how much is absorbed of the vitamin C, but you will lose a certain amount of activity by taking vitamin C at the same time as you take your Velcade.
Okay, and then because I've been on vitamin C and been told not to take vitamin C, and when you go back on vitamin C, it's mostly for to boost your immune system while you're in a remission type status. Is that correct?
That's one of the reasons. Vitamin C is an antioxidant agent, and so it helps people. Whether it's at low doses has any major effect on the immune system or not, that's still all debatable.
Okay.
But in general, it's good to take some additional vitamin.
Right. Okay. And I know earlier you explained the presence of iron. So when you were doing this experiment, you used patients with MGUS, patients with smoldering myeloma, and patients with active myeloma. And you were saying that you didn't see the impact on the MGUS as you did on the active myeloma, and they had less iron than they did. What about on smoldering myeloma patients? I guess that depends if they're high-risk smoldering, or does it, I wonder.
The problem is that we have relatively limited numbers of MGUS and smoldering myeloma patients that we studied. But the smoldering myelomas, in terms of how much iron they had in their cells, was relatively similar to myeloma, while it was much, much lower in MCAS patients.
Mm-hmm.
So
and I know you're trying. You said
you would expect that they would do relatively well with vitamin C alone, and to just as a proof of principle, to give those patients vitamin C for a while and see whether we can really kill their smoldering myeloma cells, I think would be important for us to show that.
Well, it'd be a pretty benign clinical trial, right? I mean, you're being infused with vitamin C.
Yeah.
Are there any risks of doing IV vitamin C that you're aware of?
There are risks. The main risk is when your kidney function is not good. If your creatinine is more than 2, you might have kidney problems with the vitamin C. So those patients are typically excluded. Patients who are on warfarin also are typically excluded, or they have to go to different anticoagulation treatments.
Okay.
And the other thing that vitamin C interferes with, if you're diabetic and you test your glucose by a glucometer, that is clearly influenced by the vitamin C. It gives you false readings. So if you take it in the blood, there's no problem, but not on the finger.
Oh, interesting. So you would have to get a lab pulled,
yes.
A blood sample taken.
Yeah, because your glucose levels are going to be totally unreliable for about 6 hours after you start the vitamin C.
Okay. And when the historical research was done in the 1970s, and I know you said the oral was done in the 1990s, was it repeated, or was it just given once? Like, let's say you're going through stem cell transplant. Usually you get melphalan once, and you don't get it repeated. You just get it once, and you get your stem cells back. So I guess this would be part of future work to study, but what would be your guess or your hypothesis about the use of vitamin C?
Yeah, in solid tumors, they usually give it twice a week for 3 weeks, so a total of 6 doses. And that's where they had the most success, and I think that we should probably stick to that. That doesn't mean that every time they have to have melphalan, but the vitamin C would still help in killing cells that were damaged initially by the high-dose melphalan.
Mm-hmm. And I think what you said was really important, that you tried it at 3 different doses, and that it was, that was really important, and that no survival differences were. In your paper, it says no survival differences were observed between low and high doses of melphalan when combined. So, how would you guess, and would you be interested in testing how this might work in conjunction with other types of myeloma treatment, like dexamethasone or the IMiDs or the monoclonal antibodies and those types of drugs? Because you've tested one IMiD, right, the carfilzomib, and you did the one proteasome inhibitor, the Velcade.
We didn't test the IMiDs, and the reason why we didn't test IMiDs is because
you're right, carfilzomib, sorry.
In an immunodeficient mouse. And as you know, IMiDs are immunomodulatory drugs, and we didn't know how much of the activity of the drug we would lose if patients have no immune system.
Oh, I see.
So have no immune system that can work. And the same thing for the monoclonal antibodies. You need to have cells that are eating up the myeloma cells that are covered with this monoclonal antibody. And it's the immunodeficient mice that we used are not optimal for this type of work.
Mm-hmm. And do they see the same thing in other blood cancers where there are high levels of iron on top of these cells, like leukemia and lymphoma?
Yes. As we all know, if you look at ferritin levels, they are very high in most malignancies, and the more aggressive the malignancy is, the higher the ferritin levels are. So there is cells need some degree of iron for them to grow and proliferate, and the cancer cells are extremely worried that they don't have enough iron in their system and that it will limit their growth. That's why they take excess amounts of iron up while they prevent the iron from being pumped out of the cell.
So they hang on to it.
Yes.
And can you help differentiate also, because you mentioned this earlier, which is true, that it's only impacting the cancerous cells versus regular healthy cells, and why that's important?
Well, an ideal drug for cancer is a drug that only kills the cells that you want to kill, the cancer cells, while has no side effects to the normal cells. It doesn't cause the bone marrow cells to decrease. It doesn't cause diarrhea. It doesn't cause nausea, vomiting, because it has no effect on those cells. And vitamin C seems to be a drug that has that major difference between normal cells, which have very low levels of iron and therefore are not going to be damaged by the vitamin C, and cancer cells, which happen to have a large amount of iron in the cells, and therefore are going to be much more damaged by the vitamin C.
Mm-hmm. And then are there any other cells in the body that have higher iron uptake in general? Or
in general,
normal cells have a normal level?
There are some congenital diseases which we call hemochromatosis, where the cells pick up much more iron than they should, and that causes ultimately liver and pancreas damage because of all the iron that's accumulated in the cells.
Well, maybe you get some side benefit by giving this type of treatment. Maybe it could kill not only cancer cells but help with other diseases before too.
It could be, yes. So
possibly.
Any type of cell that has a high amount of iron, in theory, should be selectively killed, while the normal cells with low amounts of iron should have no side effects.
Mm-hmm. So, in the future, I know you mentioned this a little bit, what you'd like to do, but if you could map out a strategy for future investigations, what would that strategy look like?
First of all, the first thing I would like to do is see if we give vitamin C alone in smoldering myeloma, is it going to work? Is it going to kill the smoldering myeloma cells? And if it is, how can we combine it with another drug that we typically don't use in myeloma for the myeloma treatment, and that we can add to the vitamin C, so that in case those patients ultimately develop myeloma, that we already have not lost quite a bit of drugs that we need later on. So that would be my ideal combination. And whether that's immune-related, like monoclonal antibodies, or the PDE1 inhibitors, those are all things that we are looking at this point in time.
Are there other drugs that you think, when you're thinking about combining it with another drug, that it's not used in myeloma therapy, beyond the monoclonal antibodies or PD-1, like other drugs and other diseases? Or you're kind of thinking just along those lines, like the immunology kind of drugs?
That's what I would like to do at this point in time, since the general belief is that why do patients develop myeloma out of smoldering myeloma or MGUS is because their immune system becomes affected, and the immune system is not as effective as it should be, and that's why they develop myeloma, because the immune system that could control the disease before and make sure that for every cell that was produced that another cell was killed, that mechanism dies off, and now the cells can proliferate, and there is much more growth than there is killing of myeloma cells, and that's how the disease goes to myeloma.
Okay, so you'd first like to test it in smoldering myeloma, and then what would be your next step? Especially in patients over the age of 65 who are not candidates for full dose melphalan, to see whether we can have good survivals by combining a quarter or a fifth of the dose of melphalan with the high dose vitamin C. Okay, that makes a lot of sense.
Yeah, and we should be able to have, based on the mice data, should have the same outcomes as if we would have given full dose melphalan.
Mm-hmm. Now, when you look at something like this, that's not a drug company drug, it's vitamin C, and and think about costs to create a clinical trial for smoldering myeloma patients, or a clinical trial for these over 65 patients who aren't transplant eligible with full doses anyway. How do you structure that to create a clinical trial over that, and is it less expensive than kind of a standard myeloma clinical trial?
Well, that all depends, as you know, how much vitamin C will be used. If it's going to be used in a much larger scales, there will be more companies making vitamin C, and there will be competition, and the price will go down. If there's not a lot of vitamin C used in high doses, then it's going to remain a relatively expensive drug. And we can only do those studies if there is some support by another mechanism like the NIH or the Leukemia Lymphoma Society or any other myeloma support group.
Mm-hmm. Yeah, that's really fascinating, because you think about vitamin C as being this ubiquitous kind of vitamin that's everywhere. So you don't really think about it as having cost, like high cost.
Yeah.
Potentially.
If you give it orally, it's cheap, but we know that doesn't work.
Mm-hmm. So tell me about dosing again, because you mentioned the dose, but I didn't write it down.
The dose is somewhere between 75 and 90 grams with each administration. And while if you and I take vitamin C, we typically take 1 gram of vitamin C.
Oh, okay. Yeah, that's almost 100 times.
Yeah, well, yes. And if you give the same amount by pills, you get about 40 times more higher levels if you give it intravenously than by pills, the same amount.
Mm-hmm.
So that's why the oral will not work. You have to give it intravenously.
And when you talk about the mice relapsing, I wonder if, some of the strategies in myeloma are get rid of the bulk of the disease and then give something else, like a vaccine or another a T-cell therapy or something like that can boost the immune system back up now that the disease has kind of been cleared out and freed up. And then there are others that are just, actual myeloma killing, get to the root of the problem kind of strategies. So how would you see this working? I know you're working on finding out why it came back, and why are the iron levels going back up, maybe?
Yeah. Ideally, as you know, when you have gone through transplantation, you would like to have treatments that are not going to affect you a lot, and that you can go back to normal life as quickly as possible.
Right.
And
right.
So that is what we are trying to do, is instead of giving the 2 years or 3 years of Velcade with an IMiD or carfilzomib with an IMiD and dexamethasone, that we can go to something that selectively kills your cancer cells but doesn't impact your quality of life.
Right. Well, that would be a game changer, complete game changer, because post-transplant, it takes a long time for you to feel like normal again. And then, I would much rather go on a vitamin C maintenance regimen, if that's possible, than something else that's, going to cause other worse side effects that'll inhibit quality of life. So. And
again, the thing that we always have to remember, and that we have clearly seen with the IMiDs, is that all those other drugs that have effects on other cells can cause problems in the long run. Like if you give Revlimid for too long, you increase your risk of leukemia and secondary tumors.
Yeah.
So if you have drugs that are only working on the cancer cells and leave the normal cells intact, you don't have those risks.
Right, and you mentioned some other, possible side effects, but they didn't seem very severe with vitamin C. Have there been other studies that have been done that have given high doses of vitamin C over longer periods of time, so you could see, so you already have that data about impact or potential side effects, if any, of vitamin C?
If you are talking about as it's been given for more than 3 or 6 months, I don't think that has been the case. All the studies that I've seen, they have been relatively limited in their scope. It was given for 3 cycles, and then people went on to the classical treatments.
So you don't know of any diseases right now that use mega doses of intravenous vitamin C to treat any particular disease?
We know that by itself it's not going to be sufficient, that we have to give this in combination. And in myeloma, we know that the best combination is with melphalan. But in other diseases, that's still it's being tried with cisplatin, with Paxil, with all those other drugs that are typically used in solid tumors, to see which one of those is the best combination.
And the reason for it being maybe more effective in blood cancers versus solid tumors, I think you kind of briefly mentioned it before, but do you want to go into more detail about why it might be an attractive target?
Yeah, because in solid tumors you have this mass of cancer cells, and it's very difficult for any type of product to basically penetrate into the middle of that solid tumor. It will do around the cells that are going to be the most affected are the cells at the outlayer, the cells that are closest to the blood vessels. But in liquid tumor cells, all the cells are basically equally exposed to the blood vessels and to the blood, and so it should work better if you do it in liquid.
Yeah, I would think so, because it can reach it, like you're saying.
Much easier to reach the target cells than in solid tumors.
Well, in clinical trials, in terms of a next step for a smoldering myeloma or an over 65 and non-transplant eligible kind of clinical trial, are you and the research team kind of working on constructing a follow-on trial? And if so, how long does that typically take?
Well, we are trying now to develop protocols that we can get through the FDA and can get our IRBs, or institutional review boards, for approval. But as you know, if you have to have something approved by the FDA, it takes its sweet time, and I think 6 to 12 is probably what we will need.
Well, I think it's very exciting work, and I think it's I know that you and Dr. Zhan and the team have worked together for a long time also, and been really instrumental in helping understand the genetics of myeloma, and so you really understand the deep dive into the research and what would work and what wouldn't. So this kind of option would be terrific for patients, just terrific. So it's very exciting.
Well, if it would work as well in humans as it is in mice, it would be very exciting. Yeah.
Were the 1970 studies done in humans, or were they mouse models also?
No, they were done in humans.
Okay. And what were they done for? I'm curious.
For all solid tumors, only solid tumors. Again, breast cancer and prostate cancer and brain cancer and all those type of things.
It's so fascinating. Well, we're so happy you're looking at it. I'm going to open it up for caller questions, and then I may have some other follow-up questions after some of our callers are finished. But if you'd like to ask Dr. Tricot a question, you can call 347-637-2631 and press 1 on your keypad. And I'll open it up for our first caller at 983-6757.
Good afternoon, Dr. Tricot. My name is Dana Holmes, And I'm a smoldering patient, so I have been finding this discussion this afternoon just fascinating. Before I ask my question, I really just want to express how grateful I, as a smoldering patient, am for your dedication and commitment to not only your myeloma patients, but to the multiple myeloma patient community. And I personally wish you only the very, very best, and am just always so grateful that specialists such as yourself take the time out to educate us and inform us and give us hope. So thank you. 20 minutes into the discussion, I was so excited when you mentioned that this was something that could potentially be used in a smoldering clinical trial. It just seems to be a dream come true for smolderers to consider something that is so much less toxic approach than what we actually have on the table right now. And I'm wondering, would this be something that would be for all subtypes of smoldering myeloma or multiple myeloma? In other words, all of the different cytogenetic abnormalities, or is it more or less for the lower risk type profile?
Our work seems to indicate that the more aggressive the disease is and the more high risk the disease is, the more the cells accumulate iron, and the more iron they accumulate, the more they should respond to the high-dose vitamin C. So this is not like only for the relatively benign types, but it's especially for the more high-risk patients with smoldering myeloma, where I would think it would work the best.
Ah, interesting. And obviously for the smoldering myeloma trial, it would be as a single agent. How do you see such a trial design? Would it be a single dose? Would it be multiple doses? Would it need to be, I know that these are probably all questions that you have to answer, but would you see it that we would need it as a long-term use in order, especially if someone responds to it, in order to continue that response?
I would think that we should try with giving 6 doses twice a week, so for about 3 weeks, and then see what the response is. In patients who respond, then we need to come up with some type of maintenance dose that is doable for the patients, that is effective enough to keep the disease under control. So those are things that we need to find out. But unless you do the clinical trials, it's very difficult to find out. And again, if we do a clinical trial, we will include all the smoldering myelomas and not just say, well, we should only take the high risk. We want to, in all of those patients, is there effect of the vitamin C by itself? If you give them combinations, then people will always say, but how do you know what the effect was of the vitamin C and the effect of the other drug? If you only give vitamin C, then you know if you see effect, it must be the vitamin C.
Yeah. Oh, my gosh, what an interesting approach. Would this be a trial, a single trial center at the University of Iowa, or do you see this as a multi-center trial?
I would like to have this done as a multi-center trial so that we can move on quickly. All of us don't have that many smoldering myelomas, and I would like to, as quickly as possible, have evidence in about 30 patients whether this is working or not. It's
just fascinating, Dr. Tricot, to think that after 3 weeks' time that you'd be able to establish whether there would be a response or not. How would you monitor a patient? Are you looking just at simply blood biomarkers, serum biomarkers, or are you looking also at bone marrow biopsies?
I think if you want to have a complete picture of how well patients are responding, then you need to look at the blood, you need to look at the bone marrow, and you need to look at imaging.
Imaging also.
Yeah. And combine those 3, then you have a pretty good idea whether you really had a clinical response.
Yeah. Oh, my gosh. Well, this just, honestly, I have nightmares about my smoldering myeloma, and I think that this has just removed some of those nightmares, just the thought of it and the hope that it holds. So I thank you, and I wish you the very, very best of luck for it, and I'm hoping that it comes to a center near me because I will be at that front door and lending my support to something like that for sure. Thank you again, sir. And Jenny, thank you so much for taking my calls.
No, thanks, Dana. Okay, our next caller is 732-0188. Go ahead with your question. Hello, go ahead with your question.
Hello?
Hi, we can hear you. Go ahead.
Oh, yes. Okay, I didn't realize it was me. Sir, thank you very much for your efforts in this regard. I am currently in remission after having a stem cell transplant last June, and because of pretty severe neuropathy in my feet, I am taking just a Velcade maintenance therapy. I take a somewhat reduced dose of Velcade once a month, and I had never heard an association between Velcade and vitamin C, and I drink about 8 ounces of orange juice each morning. Is that something I should discontinue?
Well, you need to discontinue that on the days that you get your Velcade. The other days is fine.
Okay, so it's only the day of the Velcade.
Yes.
Okay. Sir, thank you very much for your efforts and taking my question.
You're welcome.
Okay, thank you so much. Well, Dr. Tricot, I had a follow-up question from one of the questions that Dana asked, and it has to do with how you say that the iron levels are higher in the higher risk gene profiles. And I mean, you've attended and spoken at our myeloma crowd roundtables before, where we talk a lot about high-risk disease. And there's a chart that you and others have shown that shows kind of the progression of someone's myeloma and how it morphs and picks up changes over time. So when you say it's more effective for the higher risk, does that mean because maybe they've been under treatment for a longer period of time and these cells are, holding on to iron and pumping more in and pumping less out over time? Or do you think that a particular genetic mutation, like let's say a deletion 17 or something like that, regardless of the length of time someone's been treated, if those have higher iron levels? I guess my question is if you've ever assessed just maybe a newly diagnosed patient with some of those things and looked at their iron levels.
Well,
does that make sense? Does my question make sense?
That's going to be part of the study that we're going to do with when we do this smoldering myeloma study and when we do the myeloma study to see whether there are differences in the different genetic groups. But again, based on what we have with limited samples of myeloma patients and the many, many different forms of myeloma that are existing, you need to have a much larger sample to say anything meaningful about that. But in theory, again, the more aggressive the disease is, the more they are going to upregulate the pump that pumps in iron, and the more that they are going to downregulate the pump that pumps out iron, and the more they are going to hold on to the iron, and the more iron there is in the cells, the better the vitamin C should work.
Okay, well, I wonder if that'll give you any indication also as to why why the iron's getting pumped in and less is getting pumped out. If it'll help indicate how to just shut that down, find something else that'll kind of put those, reset those, I guess, to normal levels, because that would be fantastic.
Yeah, but we can do this artificially in cell lines, and that's what we did. The pump that pumps out iron, we can make sure that it pumps much harder and it's much more of that protein in. And if we do that, the levels of iron decrease in the myeloma cells, and you see less killing of myeloma cells with the vitamin C. And on the other hand, if you bind iron with desferoxamine, you see the same thing. While if you incubate cells with iron and they take more iron up and the levels are increasing in the cells, you see more killing. So it's clearly related to the level of iron in the cells. But what level of iron you need to have to see killing and below what level you will not see any killing, those are all things that we don't know yet.
Mm-hmm. Well, this is a very important discovery, and I'm just really thrilled that you've joined us today to describe how it works and to clarify things for patients, and to give us something new and exciting to look at, look ahead for. So this is terrific, and we're really, really grateful that you joined us today. Yes, I don't know how retirement works, but I don't know if you can continue to be involved in research like this. But if not, you're going to be incredibly missed. So we want to see these as patients. We want to see these keep going.
Yeah, but I will always be involved to some degree, more as a consultant than really as an active member. But I will always be involved to some degree because I think I have some experience that can be helpful.
Well, in my opinion, you're one of the great examples of the value of seeing a myeloma specialist, and I say this almost on every show, I feel like. But going to someone like you who's been treating myeloma for 20 plus years versus going to a local oncologist, you can just see the depth of experience in every aspect of the treatment, and on the research side, you've seen some of everything. So you know how these things interact and relate with one another, and can, sometimes serendipity comes from looking at some work that's been done 20 years ago that you remember, or 30, or, from the 70s. So
and then
to me, this is just a great example of that.
Yeah, and being an institution that had interest in vitamin C. As many times in life, sometimes those things happen by accident and not really planned.
Mhm. And tell us a little more about the history of vitamin C research at the University of Iowa, because that sounds like it's an important piece.
Yes, our radiation therapy group, they have major interest in vitamin C, and initially we didn't know that, but after a while, when working with people here, we saw that was potentially interesting, and when we went to their seminars and we heard what they were doing, and we thought, well, we need to try this out in liquid cancer. So you would think that this is going to work better in liquid cancers than in solid tumor cancers, and that's how we started to do those things.
Mm-hmm. Well, it's just so fascinating. So thank you for your incredible work. Thank you for being such a wonderful doctor for both me and everyone else. And I don't want to cry again, so I'm going to try not to. But I just want to thank you for your decades of service to the myeloma patient community.
Thank you very much.
Well, thank you to our listeners for listening to Myeloma Crowd Radio. And we invite you to listen to our next episode to learn more about the latest in myeloma research and what it means for you.
Hello, it is Ryan, and we could all use an extra bright spot in our day, couldn't we? Just to make up for things like sitting in traffic, doing the dishes, counting your steps, all the mundane stuff. That is why I'm such a big fan of Chumba Casino. Chumba Casino has all your favorite social casino-style games that you can play for free anytime, anywhere with daily bonuses. That should brighten your day a little. Actually, a lot. So sign up now at ChumbaCasino.com. That's ChumbaCasino.com.
No purchase necessary. VGW Group. Void where prohibited by law. See terms and conditions. 18+.